Welcome. We're here at the 12th workshop for Non-Hodgkin's lymphoma, and with me we have a distinguished group of myeloma doctors talking to lymphoma doctors, and you may wonder why. Well, we're invited with a specific purpose of sharing ideas on how both of our fields connect or not, perhaps thinking outside of the box. So it's my pleasure to introduce Professor Keith Stewart from Mayo Clinic, a colleague of mine, myeloma expert, Professor Leif Bergsagel, also a myeloma expert with classic expertise in mouse models on basic biology and multiple myeloma. And my name is Rafael Fonseca. I'm also a hematologist at the Mayo Clinic. Welcome.
Welcome.
So today we talked about lymphoma and how that relates to multiple myeloma. Keith, do you mind starting a little bit of the concepts that we discussed, including, for instance, genomic instability, clonal heterogeneity? What does that mean for the patient, and how does that relate to therapy?
Well, I think in your talk today, Rafael, you described how myeloma patients have multiple clones present at diagnosis that come and go in response to treatment, but often it's the very small and more aggressive clone that ends up being the clinical problem for the patient. And we drew a lot of parallels to the situation in lymphoma, particularly in the more indolent follicular lymphomas, where we suspect the same phenomenon is occurring. The implications for us were that you need multiple drugs to eradicate disease, that using one or two drugs is not likely to be a very viable long-term strategy, and secondly, that there is probably a strong role for drugs that work independently of the genome within the cell, because that is really our challenge. The genome is so complex and so heterogeneous that we really need drugs which are agnostic to that. I think those were probably the two take-home messages.
Leif made a comment during his presentation of how we've learned a lot and made progress to empiricism, yet myeloma, like many of the lymphomas, are some of the diseases where we know the most about biology. Any ideas on how we can bring these two things together? I mean, is there hope for a future for individualized or precision medicine for myeloma patients or for aggressive lymphoma patients?
I think one of the lessons I feel we've learned through the genome revolution has been that most cancers share these features. This isn't unique to myeloma, it's not unique to lymphoma. Each of them have this clonal heterogeneity, and it's going to be a challenge for individualized medicine to pinpoint each of the individual mutations in a specific tumor, which again I think is why we will probably need that. We will need those individualized therapies, but we'll need to supplement them with something which is agnostic, like a monoclonal antibody, for example, which targets it, or an immune-based therapy which doesn't care what the genome looks like.
Leif, your work has been fundamental in understanding the basic biology of the disease and some of the core abnormalities. You talked at this meeting about MYC. Would you mind expanding a little bit about that and how that relates to the concept of subclones, et cetera?
Sure. So, MYC is one of the oldest cancer-causing genes that we know about. And it's amazing that we can still learn new things about it 30 years after it was first reported to be involved in lymphoma and multiple myeloma. And so a surprising thing is that there are many different ways in which this oncogene can get turned on, and ways that we didn't appreciate before. So it turns out to be a much more common event, at least in multiple myeloma. And in lymphoma, and particularly the diffuse large B-cell lymphoma, it's recently been shown to be a very critical prognostic factor, identifying patients that do poorly. And so I think what we've learned from myeloma is that you don't always have the MYC at the beginning, but it's something that can be acquired as you progress from the pre-malignant to the malignant condition, and that can be associated with presence of different clones with and without it.
One of the things you also talked about in this meeting, which is a concept that none of us have really worked extensively in the past, you're heavily engaged now, is this whole concept of permissive or supportive microenvironment. Could you explain that just in broad terms to the audience? How does that matter for disease progression?
Yeah. Well, so the tumor cells, lymphoma or myeloma, don't grow in isolation. They really grow in an environment of cells that support their growth. And some of those cells can be like blood vessels, but they can also be other immune cells. And it turns out that the immune response to cancer can both be helpful for the tumor as well as detrimental. And there's the balance that the tumor, if it manages to grow, has to control that immune response. And there's different kinds of therapies that are being developed now that seek to alter the balance, where the immune system no longer either allows or supports the tumor growth, but you can inhibit that. One we didn't even talk about today, but our checkpoint blockades have been explored and are showing promise. And what we talked today was about doing that with a type of microenvironmental cell we call macrophages, and to see if we can turn them around from supporting the tumor growth to killing the tumor.
Great. If I could ask you both, after we finish the meeting, each one of you probably has a thought of something else you want to say to the audience. So what can myeloma doctors teach lymphoma doctors? And to be fair, I'm going to start so you can think about your answer. And one of the things I think we've learned, and again, you alluded to this empirical concept and the importance of paying close attention in the clinic. We heard from Keith that some of the work being done, for instance, in understanding the mechanisms of resistance or action of lenalidomide led to beautiful papers recently that showed that the whole process of ubiquitination and proteasomal degradation of Ikaros is important. So if you had read that paper before the clinical trials were done of the combination of IMiDs and proteasome inhibitors, no IRB would have allowed that trial to happen. So I think it's interesting how the sequence occurred. And there's a lot of bench to bedside, but there's just as much value in the bedside to the bench. And I think that for me is one of the important concepts, because as we try to get smart about these things, it's very clear we don't have the full answers. Keith, any brilliant thoughts that are left there that you can share with our lymphoma colleagues?
I thought one of the more fascinating things was the emerging role of macrophages and the innate immune system in controlling tumors. And I really think that now we know some of the keys to how our drugs work. For example, the class of drugs we call immune modulators, thalidomide, lenalidomide, pomalidomide, all have this dual activity of both killing the tumor cell and stimulating the immune system at the same time. And what we haven't really been able to unravel is what the relative contributions of those two sides of the same coin are. And I think Leif's work with macrophages and the effect of these drugs we're talking about on tumor necrosis factor, for example, how that interplays and interacts, that's really a fascinating area for ripe for discovery, I think.
Very, very interesting.
Yeah. And I guess I would go back to Mick. You know, it seems like there's still something more that we can learn about it. It seems to be such a critical factor in lymphoma, identifying these people that do poorly. And so to explore further ways of targeting MYC. And in fact, we talked about how drugs like Revlimid and pomalidomide is one way, at least Keith talked about one way that you can target MYC. But there are new classes of drugs being developed that may represent other ways. They're called bromodomain inhibitors. And I think really focusing still on MYC is a key to success both in lymphoma and myeloma.
Well, thank you both. Even though we all work together, I found this morning's sessions very illustrative and I learned quite a bit. So thank you.